Why don't we?
Righty. Okay, Robert, what do you think of this case?
Let's
Oh,
see.
hold it here. Why is that? Oh, sorry about that. I've got to turn the projector on here. Just give us a second.
Sure.
Okay. Okay. Okay, go ahead, Robert.
Okay. Let's see. Looking at the patellar tendon, it looks like there's some mild thickening proximally.
Okay, but it's kind of subtle with a little increased signal intensity, right?
Right.
Okay. And then so you're talking about right in that area. Okay,
Right.
so the patient now has increasing pain, and 7 months later, this is what the image looked like.
Now that's diffusely thickened and increased in signal. So pretty extensive tendinosis.
Yeah, so that's kind of patellar tendinosis, and it's common in ligaments and tendons throughout the body. We've seen it everywhere. This is really microscopically, it's disruption of the type 1 collagen fibers and the cross links within the tissue. Then you get granulation tissue to try to heal it. And it's really due to chronic repetitive micro tears within the collagen fibers within the tendon. So we
Do you happen to know what the patient was doing to cause this?
I do not know. Yeah.
You look at the skin, it looks like abnormal. So it looks like kneeling or something of that sort.
I don't know. Okay, what do you think of this one, Taysom?
Right, so it looks like we do have patellar tendinosis, but there's also some disruption of the deep fibers near the proximal aspect.
So this is a little bit more focal, which we can see here with some disruption of the, as you say, the fibers here. We can see. So this is really kind of more like a partial tear. When what happens, you get tendinosis, you get weakening of the tendon, and that leads to increased risk for partial tears and then eventually complete tears. And here we can see the increased signal intensity on the coronal proton density fat suppressed sequence, where we see the edema within the tendon. So this is more severe tendinosis with the developing of an early partial tear.
That's just about ready to tear from the patella. And that's not a good thing to get.
Okay.
If it's fixable, but it lays you out for about 6 months to a year.
Okay, so here looking at the patellar tendon posteriorly, there's increased signal. It's pretty uniform. There's patella baja as well. Looks like a shortened
I
patella.
wouldn't call this patella baja.
Okay.
If you look at the articular cartilage, remember that's really what's important. You're just having articulation between the inferior portion of the patellar articular cartilage and the superior part of the trochlea. So that's really kind of normal. What's the problem here is that you've got a large inferior pole of the patella. If you didn't have a large inferior pole, then the patellar tendon would be longer. It would insert about here. And but what happens with a prominent inferior pole, you have a much more rigid area in through here, which is the patella itself. It looks like the patellar tendon is short, but the total distance between the tibial tubercle and the inferior aspect of where the articular cartilage is really pretty normal. But when this makes it rigid, what happens is that you have abnormal direction of forces here because the patella extends too far inferiorly here. When the patellar tendon attaches to it, this is a big moment arm, and it's tending to pull the inferior aspect of the patella more posteriorly here. But what this does then is means that this causes much more variations in the strain pattern on the patellar tendon. And I think these large inferior poles of the patella significantly predisposed to patellar tendinosis because of the stretching that you get of the tendon due to this abnormally rigid lever arm.
Flexion becomes a real problem in this condition, past 90 degrees.
Okay. All right, Greg?
So 33-year-old MLB player with anterior knee pain. So again, we see increased signal intensity at the proximal patellar pole, the patellar tendon. So patellar tendinosis.
Okay, so this patient had severe pain over several years. It got to the point where it was incapacitating, so they then did surgery.
Okay, so now post-op without symptoms, can he proceed to full practice? So it looks like there's, I guess, post-operative change within the patellar tendon thickening. I guess maybe some scar tissue. I'm not sure. It looks like it's healed. It looks like it's intact.
Yeah, so would you tell him it's okay for him to practice?
Sure.
So did I. He did okay. Okay. With the criteria, we don't have any data to really know, but I think when you see on a T2 weighted image, this is PD, this is T2. If you don't see a lot of fluid here and it looks like scarring, the fibrous tissue goes all the way to the bone, that's probably reasonable.
It looks to me, John, like the distal pole has been transversely cut.
Well, here
And
you can see
attached.
that it's kind of rounded, and here,
Yeah, right, and then reattached to
yeah,
the patellar tendon.
you can see the metal artifact here. So they kind of implanted the posterior
Yeah,
aspect of the
because
patella.
otherwise it doesn't work any other way.
Yeah. Robert.
Here it looks like there's a partial tear of the distal patellar tendon.
Yeah, so this was a little partial tear. It was symptomatic, and this was treated conservatively, and the patient got better over several months. Okay. Tayson?
All right, so we have tendinosis with intersubstance tearing of the patella.
Yeah, right. So this is a partial tear, which we can see here, kind of longitudinal, right?
Yeah.
And then here's another athlete where we can see a high-grade partial tear, approximately similar to that one that was operated on before. So you can see there.
So here, increased signal, the proximal patellar tendon. This chronic knee pain. So I'm seeing intact fibers on the T2, so maybe some tendinosis.
Yeah, so these kind of get chronic pain, you get stretching and so forth, you get partial tears, you end up with those microscopic tears and tendinosis. But if you continue to have strain on it, then those can coalesce into bigger tears and you can get partial tears. So this was called a partial tear, that inferior surface. And then here,
Did they do anything?
yes, here you can see, here
Okay.
they did surgery to reimplant it. I don't know, that's, I guess,
Why did they do that? I mean, the procedure that I'm looking at is not the way I would do it.
so
What you do is remove the distal pole portion of it and then reattach it with drill holes and sutures. What is that going through the patella? I don't know.
I've seen many different procedures here. This particular one looks like a suture anchor here that's more on the anterior surface. But you notice here there's a defect in the subchondral bone posteriorly, and it looks like there's a full thickness fissure going through the articular cartilage in that location. Most of the time, what I've seen, John, maybe this is what you do, is that they basically put 3 longitudinal tunnels in the patella and put 3 sutures anchoring either the superior or inferior at the poles, depending upon whether it's the quadricep torn or the
That's,
patella torn, and tie it in.
that's precisely what I do.
Yeah.
You go all the way superior, just make K-wire drill holes, which is thin drill holes, and just put sutures up to the top and tie them up on superior to the patella.
That's what I've usually seen. Yeah. Is Robert next? Oh.
34-year-old male with pain and swelling 1 day post injury. It looks like, so we have sagittal images of the knee. It looks like there's laxity in the patellar tendon.
So the other thing that can happen when you get tendinosis and the microscopic tears and weakening of the collagen fibers in the tendon, you can actually get stretching injuries of the tendon. As you can see here, where it's stretched out, no longer mechanically functioning properly, and this is a chronic stretch injury.
Where is the inferior pole, or are we missing it on the cut?
Well, here's the inferior pole. I don't think this patient's had surgery, but I can't guarantee that he hasn't.
I mean, it might have been a tear, a fracture.
Yeah, I didn't have a history of a tear at the time, but possible. Yeah. Okay, Robert.
All right. So here it looks like, again, the patella tendon looks pretty lax and orange, some patella alta,
Yeah.
sense of edema.
Right, patella alta. The last case had patella alta as well. A lot of edema in the soft tissues, obviously very incompetent patellar tendon. So this is 12306. Patient came back on 51007. What's happened here?
I mean, it looks more top now. Looks like there's probably some susceptibility artifacts, so screw in the inferior pole of the patella.
Yeah. So they basically resected part of the proximal patellar tendon here, reimplanted it on the inferior pole. Patient still has a little bit of patella alta, as you can see here. So a lot of tendinopathy within the residual patellar tendon. And that was a suture anchor repair.
All right. There's patella alta with avulsion of the proximal patellar tendon.
Yeah, so it's really a complete rupture of the patellar tendon. I don't see any bony avulsion here. I think this was just a tear of the tendon at its insertion. Okay.
Okay, and here we see a complete tear of the patellar tendon distally.
So what do you think?
Almost looks like a cut.
I think hyperflexion, maybe.
Hyperflexion. Well, notice that on all these other tears, the edges of the tendon is very indistinct.
Mm-hmm.
In this one, as John was going to refer to, but I cut him off, the end of the tendon is very sharp here.
Mm-hmm.
So most of the tears that occur normally are in abnormal tendons. In fact, there's a cadaver study of the shoulder that we'll talk about when we get to the shoulder, where they looked at the histology of supraspinatus tendons in a large series of patients who went to surgery. And they found that 100% of the tendons that tore had evidence of chronic tendinosis in the adjacent tendon. So basically, normal tendons don't tear. In this case, this looks like a normal tendon coming down here, and this was a laceration.
Sagittal image of the knee. Looks like there's increased signal within the proximal patellar tendon. There's also looks like it extends more superior to where you have like the what you call the quadriceps expansion, or and then there's a regular signal within the patella. Um,
So what do you think the mechanism is here?
um, acute trauma to the anterior knee.
Yeah, this was an impaction injury. So this is a bone contusion, and this was some tearing of the patellar tendon due to an impacted trauma. Yeah. Robert.
All right, so we have a 12-year-old male with knee pain. It looks like there's an avulsion of the inferior pole of the patella.
Right. And this is a little bit chronic. You can see it's eburnated on both sides. You like to detect these and pick them up kind of early. Here's a stir image showing that. And these are called patellar sleeve avulsions. John, what do you want to educate us about these kind of injuries?
They're pretty rare. But in this one, I just would put the patient in immobilizer and let it heal.
Okay. Good.
If it was an adult, that one might be a different story.
Okay. Thank you. All right.
All right, looks like we have a transverse fracture through the patellar body with distraction of the
Right.
fragment.
So here's a transverse fracture, and the distal pole is significantly angulated so that the cortical margins are no longer lined up, as we can see in this patient, and this is a patellar fracture. So what would you do with this one, John?
On this one, I would try to put the bone back, but you might have to do a little sculpting to put it back in proper place. It depends on how even it is, and it doesn't look very even there. So it's hard to put back something that's crooked. So you might want to remove a portion of the patella proximal and distal and put it together evenly, and then put screws through it.
Okay. So, but you treat this surgically.
Yeah, this is you cannot treat
Right.
any other way. That would work.
Yep.
This is definitely a surgical procedure,
Yep.
and so is this one.
Yeah, here's a fracture of the transverse fracture of the distal patella. Looks like the much of the patellar tendon is intact though on
Yeah,
this
so
one.
that quadriceps expansion is still intact, but you see a fracture right here. And it looks like it's probably going through the inferior articular. Well, I don't know. It's hard to say. This may just be the inferior pole, and the cartilage may still be intact superior to it. So this looks like it's just a fracture of a prominent inferior pole.
Actually, this one might work with a suture anchor,
Okay.
but I've never used a suture anchor in these. But this might cause me to do it.
75-year-old female with chronic knee pain. It looks like there's increased edema within the proximal quadriceps.
Proximal what?
Is it the quadriceps?
Well, the quadriceps would be up
Up
here.
there,
We're not
okay.
really seeing the quadriceps. This is the patella. This is the patella.
Oh, so it's
Sagittal.
so you have two separate pieces of the patella.
Here's the axial right through this area. So what are we dealing with here?
Looks like a normal knee to me.
Ah,
Where'd you do your orthopedic training, John?
Which one would you remove? The distal one or the proximal one?
I-
So this is a chronic transverse fracture.
oh,
And the margins are corticated on either side. So, yeah. So this is a chronic patellar fracture. And I assume, John, you'd take out the inferior one and reattach the patellar tendon?
That's the way I would do it.
Okay, yeah.
And you might have to give it more length by doing a Z-plasty of the quadriceps tendon
Okay,
to lengthen it,
yeah. It looks like it's
but
chronically
probably not
retracted
that
here.
much.
Probably chronically retracted. Okay.
But the distal one has to be removed.
Okay, okay, Robert.
All right. See, just some irregularity of the lateral patellar facet. I think there's probably a fracture.
Right there.
Mhm.
Okay, so, and then we can see that there's a linear thing here. So what would your differential be here? Besides, what else could it be besides a fracture?
Guess it could be.
Well, let's say there's no edema in the bone here. You just saw a little separation of the lateral margin of the patella from the central patella, but no edema.
I know you can get a defect there, but
It starts with a B.
Yeah.
over
So this was actually a vertical fracture, and here you can see edema with the bones. You see probably a break through the articular cartilage here. Okay, okay. So this is a fracture. Tayson, what do you think of this next case?
What I was saying, John,
Corrugated, so
that bipartite patella.
bipartite, yeah.
Yeah, we're getting there, John. Go ahead.
I know you are.
Yeah, so probably a bipartite patella.
Okay, and then here the axial image, and here you can see the cortical margins on both sides. This looks like a second fragment, and we can see articular cartilage below it here. And this is a bipartite patella. Bipartite patellas are much more common than fractured patellas. It's pretty common. It's thought to be a congenital variant, though a few of them may be fractures in childhood that kind of heal without a problem. But here, this is a bipartite patella, typically considered a normal variant. John, did you want to say something about bipartite patella?
Did you ask me anything?
Yeah. Did you want to tell us something about bipartite patellas?
Well, you can peel that out surgically and reattach the soft tissue to the large patella.
Okay, thanks.
So it's you can do it surgically or let the patient live with it if they want to. But the results are pretty good if you excise it properly. It's a shelling procedure.
Okay.
You shell it out.
Yeah, most of
and
these
then
in my
reattach
experience
the
are,
tendon to the patella.
yeah, most of these in my experience are kind of left alone. But if they're symptomatic, then you need to do something.
That is exactly right.
Yeah. So let's go on and talk about the other end of the patellar tendon, Osgood-Schlatter disease. There is a kind of a grading system, Hirano, which you have a normal tendon. In early disease, you can get edema in the tibial tuberosity. More progressive disease, you can start getting a bone avulsion or a partial avulsion. Then you can get a complete avulsion, and then eventually you can get bone healing. Not all Osgood-Schlatter disease fit nicely into this kind of grading system. So let's look at the distal patellar tendon for a little bit.
Okay, so we see thickening of the distal patellar tendon. We have some what looks like bone signal.
This is probably fluid. This is a T2 weighted image. This is probably fluid.
Okay. So
The bone looks pretty normal here.
yeah. So if it's fluid, maybe a partial tear.
Yeah, so this is a partial tear, partial insertional tear. This is in an older individual. As we can see here, this is not in a child. So this really isn't Osgood-Schlatter disease, but it is kind of a low-grade lesion where you actually have a partial tear of the tendon at its distal insertion. Okay,
Oh, where's the tubercle, John?
this is the tubercle right here. Not very
That's
prominent.
not much of a tubercle.
Right. Okay. Greg?
So we have sagittal and coronal images. Looks like there's increased signal within the distal patellar tendon at the tibial insertion.
Yeah.
I don't see.
Well, most of this edema is not in the tendon, right?
It's in the bone.
Yeah. In fact, Osgood-Schlatter disease in almost all cases really is a childhood disease. And in children, tendons are very strong. It's the bone that's the weak link. So true Osgood-Schlatter disease, the first stage of this really is edema within the bone like we're seeing here. So if you go back to Hirano, that would be where you get tuberosity edema. And so this would be kind of a stage 1 disease where you just have traction injury to the bone as a cause of the symptoms.
All of these can be treated conservatively and they'll never have any problems. The problem is the parents and the child, they will not follow directions.
Yeah, they won't allow it to heal. So
what I used to do is I put them in a cast so they couldn't take it off. But guess what? Some of them would take it off.
okay.
And then they would come back begging for another one or whatever.
Okay. Robert, what do you think of this case?
There's some thickening of the distal patellar tendon, and there's a small osseous fragment there.
Okay, so this is the next stage. This is the next stage where you start getting a bone fragment pulled off the bone here in this particular case. And notice there's less bone edema here, but now you got an avulsion fracture. John?
We used to call this fragmentation
Okay, good.
in X-ray days.
Yeah, okay.
All right, so now we see a lot more cortical irregularity at the tibial tubercle, and there's an ossicle embedded within the
Right.
distal patellar tendon.
And here the margins are relatively sharp, and this is the healing phase of the disease. And you can be left with one or more ossicles within the distal patellar tendon, and this is typically what we see in older individuals with chronic Osgood-Schlatter disease. And you guys have all seen it on plain films. It can become quite prominent. Here's a more severe case. If they continue to injure this, not allow it to heal, the body tries to heal itself, then you tear it more and you get more scar tissue, and you can really get large masses here due to this if patients are non-compliant and don't allow this to heal. Okay.
Rest, and more rest. This is an extremely common condition in children,
Okay.
especially boys.
So here at that tibial tuberosity, I mean, there's just mixed signal. Doesn't look like bone. Just looks like fibrous tissue,
So
maybe.
this is another chronic phase. Instead of getting bone displacements here with fractures, what you can get is just hypertrophic bone formation here. And if you continue to injure it, you continue to have a healing response, which is more granulation tissue rather than edema or fat. So this is another old Osgood-Schlatter disease. Looks a little different. So show a different number of these because they can all look a little bit differently.
It's also causing patella baja because it's pulling the patellar tendon distally by pushing it anteriorly.
Okay.
That's your way of calling it, isn't it?
Right.
The articular surfaces.
Yep.
So sagittal images, looks like there's kind of increased signal and thickening of the patellar tendon kind of throughout. And then at the tibial insertion on this fluid sensitive sequence, it looks like we have maybe a little bony fragment starting to form.
So this is in an adult. So this would be atypical of standard Osgood-Schlatter we see. We can also see there's a lot of edema and Hoffa's fat pad in this particular case, and this is a avulsion fracture in an adult with hemorrhage into the Hoffa's fat pad.
Would you call this a traumatic event, John?
In this particular case, I think this was acute on top of chronic. I think they had chronic tendinosis here, but this patient had an acute injury with acute anterior knee pain. So I think this fracture was acute, and the hemorrhage into the Hoffa's fat pad was probably acute, but this signal was probably all chronic tendinosis. Robert.
Immobilization.
Yeah. I think this is a case that I had when I was in Santa Barbara.
So what is the pathology? It's a good question. Looks like there's almost like a well-articulated cystic lesion.
Yeah, it's kind of a funny little lesion there, right in the area where you have the infrapatellar bursa here. It doesn't really look like it's an avulsion injury of bone from the tibial tubercle, but it certainly is having mass effect upon the distal patellar tendon. So this patient was actually sent up to Stanford where they removed this. And this was a synovial chondroma in the infrapatellar bursa here.
That is funky.
Okay, so this is this case. This is in an adult. That was in a child. What do you think of this one, Jason?
We have a round lesion, low signal on all sequences. There's some fibrous tissue.
Yeah, well, this is armed a few years ago, having had that other case. We made the prospective diagnosis of a synovial chondroma, and this was also removed and was an synovial chondroma that had ossified.
Okay.
No, that's pretty rare.
I think these are the only two cases that I've seen over the years.
Okay, so here, some irregularity with the anterior tibia, some edema there.
Could be cartilage, because you have a growth cartilage there for the tibial tubercle. Obviously, there's a little avulsion injury here. So this patient's putting a lot of stress on that knee. This patient was a 9-year-old with stiffness and burning in the knee. And here. And so this is.
What do you think of the
Sorry,
doctor's
Dr.
name
Anderson.
that reported it?
Well, John?
Look at the doctor who reported the case. Boy, that's a difficult one to be with.
Yeah, right. And then so stiffness and burning, and this is siding Larsson-Johansson syndrome. John, do you want to tell us what this is?
That looks to me like, oh, you mean a syndrome?
Yeah, right.
I really don't know much about these syndromes, but they involve all the various different parts of the body, not just that little tubercle in a patella. Probably a little avulsion.
Yeah, it's again, it could painful. It's a kind of an acute phase of traction injury. Right.
And these individuals usually don't do too much physically, and so it's probably a little unusual to see any bone problems like this.
Okay.
That look traumatic.
Okay.
So a 0-month-old rule out cellulitis. So on the top we have multiple ultrasound images. Are we looking at the hip? Quite sure. Where we are, it looks like there's increased signal within the muscle tissue of the thighs, so circumferential throughout the muscle tissue.
This was just patient presented with anterior knee pain, and this was all a overuse injury to the quadriceps muscles, and this was all muscle edema from overexercise. Okay, so why don't we stop here, and we'll start inflammatory disease of the knee tomorrow. Thanks, everyone.
Thank you. Thank you.
Uh, you're taking off, John?
Yeah, we're finished today, and we'll start again tomorrow. Okay.
Okay, doke.
Thanks.